Principles of Electrophysiological Studies, EPS. The electrophysiologist performs two main jobs, using the same electrode catheters. Recording the heart's electrical signals. Pacing from localized areas within the heart. Analysis of the obtained information will answer the raised questions. Cycle length, CL. One of the expressions, commonly used in EPS, is the cycle length, CL, which is the time in milliseconds between heartbeats. Since 1 minute equals 60 seconds equals 60,000 milliseconds. Then, the heart rate, in beats per minute equals 60,000 divided by the CL in milliseconds. Consequently, tachycardia, heart rate greater than 100 beats per minute, is defined as CL less than 600 milliseconds. Bradycardia, heart rate less than 60 beats per minute, is defined as CL greater than 1000 milliseconds. Coupling interval. When using a pacemaker to introduce an atrial premature beat, atrial extrastimulus, EES, or a ventricular extrastimulus, VES, the coupling interval, CI, is the time between the last normal or paced impulse and the EES or VES. Incremental pacing. Incremental pacing is performed either by pacing at CL less than basic CL, heart rate faster than basic heart rate, or by progressively increasing the pacing rate. For demonstration, this figure shows a sinus beat, followed by right ventricular apex, RVA, pacing at a cycle length of 400 milliseconds, followed by VES at a coupling interval of 250 milliseconds. Frequency unit, the Hertz. A frequency of 1 Hz equals 1 cycle per second. Thus, a heart rate of 1 Hz means 1 beat per second, or 60 beats per minute, or CL of 1000 milliseconds. For comparison, the home electric current frequency is usually 60 Hz, 60 cycles per second, that is 60 times 60 equals 3600 cycles per minute, or CL of 60,000 divided by 3600 equals 16.66 milliseconds. For demonstration, this schematic shows a heart rate of about 300 per minute. The home electric current is 12 times more rapid. Electrode catheters. An electrode catheter consists of an insulated wire, with exposed electrodes, connected to its distal part, the inner part introduced inside the heart, and a plug connected to its proximal outside end. The electrodes get in contact with the heart tissue, and are used for recording and pacing. The plug is connected outside with the recording or the pacing device. This schematic shows a quadripolar electrode catheter, with 4 electrodes connected to the distal internal end. Number 1 is the nearest to the tip of the catheter. Each external plug outside is connected to the corresponding electrode order. Intracardiac ECG. The intracardiac ECG is the graphic representation of the electrical activity of the heart, recorded by intracardiac electrode catheters. The major difference between the surface and the intracardiac ECG is that, the surface ECG gives a summation of the electrical activity of the whole heart, while intracardiac ECG records the electrical activity of localized areas. The onset of the intracardiac tracing is the precise moment of myocardial depolarization, at the site of recording, allowing precise calculation of time intervals. As shown, the onset of intracardiac V wave, and phase 0 of the action potential, are simultaneous, which almost corresponds to the onset of the QRS complex, in the surface ECG. Electronic filtering. The intracardiac ECG is electronically filtered, through a series of filters, so that only the rapid depolarization phase 0 of the action potential is recorded. The onset of intracardiac tracing, thus, represents the precise moment at which myocardial depolarization starts, at the electrode site, as just mentioned. Noise filters. The noise filter removes the noise signals of the electronic source, produced by the system circuits, and those of the power line. The high-pass filter allows the higher frequencies to pass, and blocks the low-frequency signals, such as the diaphragmatic myopotentials, and the far-field signals from other heart chambers. The low-pass filter allows lower frequencies to pass, and blocks the high-frequency environmental noise. Conduction times and mapping. Using enough catheters, in different intracardiac positions, allows for calculation of conduction times between two specified positions, and mapping the sequence of myocardial activation, electrical wave pathway, from one point to the other. Pacing. Pacing can be done from almost any desired intracardiac location, using impulses delivered from an external programmable stimulator, a process called programmed electrical stimulation. Pacing types. Two types of pacing are used in EPS. Extra stimulation, that is, delivering extra stimuli, premature impulses, at precisely timed coupling intervals. And incremental, burst, or ramp pacing, that is, introducing a train of impulses, either some beats or pacing for several minutes, at a fixed cycle length, but faster than the basic rhythm. Extra stimulation. An extra stimulus may be introduced following an intrinsic impulse, but usually introduced following a train of incremental pacing for 8 beats, to stabilize the CL before the extra stimulus. S1, stimulus 1, nominates all impulses of the intrinsic or the paced rhythm before introducing the extra stimuli, S2 is the first extra stimulus, S3 is the second, and S4 is the third programmed extra stimulus, and so on. EPS equipment. EPS laboratory should contain most of the equipment in the usual cardiac catheterization laboratories, plus equipment to deal with cardiac emergencies, and specific equipment for EPS, which includes a physiological recorder, a programmable stimulator, and a junction box. Both the recorder and stimulator are utilizing the same electrode catheters. Physiological recorder. This is a computer-based recorder, which records several surface ECG and intracardiac ECG leads, allows color-coded lead recordings, and uses electronic calipers for precise measurements of intervals. It contains a hard disk storage, for the entire studies. Programmable stimulator. The programmable stimulator, used in EPS, is a specialized pacing device, different from the usual pacemakers, and characterized by the following. It can introduce complex sequences of paced beats, with an accuracy of within 1 millisecond. Can synchronize pacing to intrinsic rhythm, and can pace multiple sites simultaneously. Junction box. The junction box allows connections between the electrode catheters, the physiological recorder, and the programmable stimulator. Patient preparation. Patient should be fasting. Should sign an informed consent. Withdraw specified drugs, especially antiarrhythmic ones. Maximal control of heart failure is essential, as well as maximal control of myocardial ischemia, and control of metabolic errors, especially electrolytes, acid-base, and fluid balance. Prevention of excessive anxiety may need a benzodiazepine, or rarely general anesthesia. Venous access. Usually, EPS is performed via the femoral vein, but upper limb veins, external jugular, internal jugular, subclavian, or brachial, may be needed, for example, in procedures requiring multiple catheters, since the femoral vein can safely accommodate only 2 catheters. When there is a contraindication to femoral approach. When catheters are planned to be kept in place after the procedure. Coronary sinus catheter is also easier to position from an upper limb vein. Catheter positions. High right atrial catheter, HRA, placed at the RA high lateral wall, near the superior vena cava and the sinoatrial node. Right ventricular apex catheter, RVA. Right ventricular outflow catheter, RVOT. Coronary sinus catheter, CS, records ECG from the left side of the heart, and can be used to pace the left atrium, but rarely used to pace the left ventricle. His bundle catheter, HB, is passed across the posterior aspect of the tricuspid valve and maneuvered to obtain the best HB signal. Left ventricular catheter, LV, is introduced via the femoral artery, but usually only needed for ablation purposes. This schematic shows the positions of the high right atrium, HRA, his bundle, HB, and right ventricular apex, RVA, catheters. His bundle, HB, catheter is passed across the posterior tricuspid valve ring. The coronary sinus runs on the posterior aspect of the heart, in the fibrous skeleton between the left atrium and ventricle, to open into the right atrium, with its mouth lying posterior to the tricuspid valve. Catheter recordings. HRA catheter records A waves from the high right atrium. HB catheter records A waves from the low right atrium, H waves from the his bundle, and V waves from the high right ventricle. CS catheter records A waves of low left atrium, and V waves of high left ventricle, usually using 5 electrode pairs. Number 1 and 2 are the most distal, the nearest to the tip of the catheter, while 9 and 10 are the most proximal, the nearest to the coronary sinus mouth. RVA catheter records V waves from the right ventricular apex. High right atrium, HRA, catheter records only A waves. His bundle HB catheter records A waves from the low right atrium, H waves from the his bundle, and V waves from the high right ventricle, that is, AHV. Coronary sinus, CS, catheter records A waves of low left atrium, and V waves of high left ventricle, that is, AV. Right ventricular apex catheter, RVA, records only V waves. Wave configuration. In intracardiac recordings, wave configuration is highly variable, unlike the surface ECG recordings. For this reason, we define intracardiac recording waves, knowing their site of recording and their timing, not with their configuration. To define the waves in all recordings, it is advisable to start with the definition of A waves in HRA channel, then V waves in RVA channel, then interpretation of the HB and CS channels will be easy. Color coding of the channel recordings facilitates interpretation, and can help avoid mistakes. Measurement of intervals. The intraatrial conduction time, IACT, is called the PA interval and is measured from the start of the P wave in the surface ECG, to the start of the A wave in the HB recording. If the P wave is not clear, use the A wave in the HRA tracing instead. The atrioventricular node, AV node, conduction time, is called the AH interval, and is measured from the start of the A wave in the HB tracing, representing low RA, to the H wave in the HB tracing, representing the His bundle itself. Obviously, the AVN is the anatomic structure between the RA and the His bundle. The intraventricular conduction time is called the HV interval, and is measured from the start of H wave to the start of V wave in the His bundle tracing. This schematic shows the PA interval, intraatrial conduction time, measured from the start of the P wave in the surface ECG, or the A wave in the HRA tracing, to the start of the A wave in the HB recording. The AH interval, AV node conduction time, measured from the start of the A wave to the H wave in the HB tracing. And the HV interval, intraventricular conduction time, measured from the start of H wave to the start of V wave in the HB tracing. The basic cycle length, CL, is the interval between successive A waves in RA ECG. The PR interval and QRS duration are measured from the surface ECG. PR interval equals PA plus AH plus HV intervals. This table shows the normal ranges, the most important of which are PA interval, 20 to 60 milliseconds. AH interval, 50 to 130 milliseconds. HV interval, 35 to 55 milliseconds. Timing of waves. Timing of any wave is defined from the earliest appearance of that wave in any tracing. For example, an A wave may be earlier in RA or in HB, or in any of the CS tracings. Its earliest appearance is considered its actual onset, which concludes the activation sequence. For example, an A wave appearing earlier in CS than in HRA, means that the left atrium is activated earlier than the right atrium, and so on. EPS protocol. EPS protocols differ according to the specific study required, but the general outlines include 1. Measurement of baseline conduction intervals. 2. Atrial pacing for assessment of sinus node automaticity and conductivity, AV node conductivity and refractoriness, and his Purkinje system conductivity and refractoriness, as well as for induction of atrial arrhythmia. 3. Ventricular pacing for assessment of retrograde conduction, from the ventricles to the atria, and induction of ventricular arrhythmia. 4. Drug testing. Cycle length, CL, and refractory periods, RP. The shorter the CL, the shorter the RP, in all tissues, but the AV node, in which the shorter the CL, the longer the RP, a property known as decremental conduction. Decremental conduction may also be noted at the sinus node right atrial junction, which is of little use in EPS, and may exceptionally be noted in the His Purkinje system. Very rarely decremental conduction occurs in the bypass tracts. Autonomic tone. Increased sympathetic tone increases conduction velocity and reduces refractory periods throughout the heart. Increased parasympathetic tone reduces conduction velocity and increases refractory periods in all cardiac tissues. Effect of parasympathetic tone on the AV node is much more than the sympathetic, since the AV node is richly supplied with parasympathetic fibers. Thank you.